In 2011, there was a study of more than 500 infants with bronchiolitis who presented to the ER for emergency evaluation and treatment. And it found that only about half of parents were actually able to identify signs of severe respiratory distress in their children. I'm Brandon. I'm a board-certified pediatrician and pediatric ICU doctor at Texas Children's Hospital. I've taken care of hundreds of infants in different settings, in the clinic, in the ER, and now mostly in the intensive care unit. The most common question I get from parents is, how do I know when I should be worried? Or how do I know that my child even has bronchiolitis? And so in the last video, we covered the basics of RSV and bronchiolitis, what it is, how does it cause infection, and then what's the relevant anatomy and what goes wrong when an infection occurs. If you have the chance to watch that, it'll make everything today make a lot more sense. But if not, we're gonna have a very practical video where we really just look at signs of respiratory distress in infants and RSV bronchiolitis specifically. So we will dive right in. We'll have this animation playing in the background as we walk through some of the classic warning signs or signs of respiratory distress. So just to say explicitly, we said that if you have RSV, it can cause upper respiratory tract infections or lower respiratory tract infections. If you just have a cold in the upper respiratory tract, you usually don't have signs of respiratory distress. Once the lungs are involved, that's when we start to see distress. And there are certain telltale signs that come up over and over again. So we'll look at those now. The first is something called retractions. We said that usually, if the infant is just breathing comfortably, the diaphragm is doing most of the work. And even though there are a bunch of muscles in the chest and the neck that can help with breathing, they're not really needed most of the time. But if the bronchioles are occluded and the airways are occluded so you can't get air in and out easily, then all of a sudden the infant really has to start flexing these muscles just to move air in and out. And so we see here in the animation that you've got these muscles in the neck, and we see evidence of suprasternal or supraclavicular retraction. So this is above the collarbone or above the breastbone. We also see down a little bit lower that there are intercostal or in between the ribs retractions where those muscles are firing and flexing quite strongly. And then finally, just below the ribs, so we say subcostal or substernal, below the breastbone, we see those as well. Looking up top, there's something called head bobbing. Well, when an infant's breathing, it almost looks like their head's going up and down with each breath kind of severely. And this is mainly because of the fact that the neck muscles are firing hard, and then the whole thorax is really just having a lot more movement relative to the head with these sort of like underdeveloped and weaker neck muscles when a child's in distress. Finally, if you look at the nose, we see some evidence of nasal flaring. And this final attempt to get air in is basically because we said that infants tend to be obligate nasal breathers, or they really prefer to breathe through their nose even when they're sick. And so instead of opening their mouths, they'll often continue to breathe through their nose. The flaring is basically an attempt to increase the surface area or open the nose as much as they can when a breath is coming in to make it easier for air to pass through and get through all that congestion, which is up here in the nose and then also down in the lungs in the bronchioles. And so I put all these things together because to me they're all associated. They're all associated with trying to get more air in and out in lungs that are sick. You can imagine, though, that let's say, despite the best efforts to get a big volume or a total amount of air that the baby wants to, they're not able to do it. In this case, they can compensate for that by breathing more quickly. And so there's something called tachypnea. This word, whenever you see P-N-E-A, it usually means that we're talking about breathing. And then tachy usually just means fast. So this just means fast breathing. So an infant usually wants to breathe at a certain speed and take in a big, nice amount of air. But if all that air can't get in, then they can compensate by taking smaller breaths faster. And so we see this quite commonly. And then finally, there's something called grunting. And we'll see a video of this, but it can be sometimes tricky to identify. And it's a little bit different than these other compensation mechanisms. So with grunting, what you'll hear is something like this. I feel a little funny doing it, but basically it is the infant's attempt to keep air pressure in the lungs. So we said in the last video that one of the problems with bronchiolitis is you have atelectasis. So the alveoli actually collapse down, and once they're collapsed, it's hard to open them back up. So when the infant breathes out, as a last attempt to prevent atelectasis, it'll actually bear down a little bit and kind of keep the lungs pressurized to keep that alveolus from collapsing down, because then it's going to be much harder to pop it back open. All right, and then the final one, this is again, it's called apnea. And again, you see that P-N-E-A. We know we're talking about breathing. In this case, A or A, it just means none. So apnea means that there's actually no breathing for a period of time. This is not really a compensation mechanism like everything else or trying to make things better. This is actually because babies just have underdeveloped respiratory drives. So there are times when they just don't have the normal response to distress and infection. And so if a child doesn't take a breath for more than 20 seconds, we say that's actually true apnea. Now, it's tough because infants actually have something called periodic breathing even when they're healthy and totally normal. And essentially it looks like this. Take a bunch of little breaths, you pause, and then you breathe again. So, and so if you see your infant doing that, that's actually pretty normal. There's nothing really to write home about or nothing worrisome. But when that's happening, it's important to note that's almost always less than 10 seconds. So it's not that long of a pause before the compensatory fast breathing comes back in. If apnea happens, it's over 20 seconds. And then in between, it's sort of hard to say, it could be worrisome, it could not be, depending on how sick the kid and other things that are going on. Children most at risk for this are those that are very young, so less than 4 weeks or premature. So I do want to know, just with the tachypnea and talking about apnea, that remember that infants actually breathe much faster than you or I breathe. So normal adult probably breathes 12 to 20 times a minute. Newborns, probably anywhere from 20 to 60 times a minute is essentially normal. And so here, this is from the American Heart Association Pediatric Advanced Life Support Guidelines. But you can see that infants breathe pretty fast, but then it gets slower the older that you get. So we've looked at a bunch of different signs and symptoms that can suggest a child has respiratory distress or isn't doing well. But when it comes time for a doctor to decide, hey, should this child go home? Can they be treated outpatient? Do they need to go to the ER? Do they need to go to the inpatient unit? And then do they need to come to me and go to the ICU? There is no universally accepted way to determine that. But a lot of these different features kind of go together. And so people have tried to quantify this and put together scoring systems like you can see here, where they'll take the infant's respiratory rate, whether they have cyanosis, which is something we didn't talk about, but a kind of blue discoloration to the skin, whether their oxygen saturation is normal, so how much oxygen is actually getting to the alveolus appropriately and getting into the body. Are they acting normally? Do they have retractions, nasal flaring? Are they feeding normally? And then what do their lungs sound like? Is there good air entry? I want to call out a couple things here. The first is, no matter what, and I know the disclaimer is here, but the purpose of this video is not to have you do a doctor or a nurse practitioner's job. Like, your job is, if you're worried, call somebody and get a pediatrician to evaluate your child, and that's totally fine. That is what they're there for. They're the ones who have to make this call, not you. I'll also say that a lot of these things you can't tell at home. So unless you have a pulse oximeter, you're not going to know what the oxygen saturation is, and then you're not going to be able to listen to the patient's lungs either to make sure that you have the right diagnosis, and then even know how much air is getting in and out when they're having distress. A couple other things I want to call out. One is feeding. So infants, they're not able to tell us that I feel like I can't breathe. Like I feel, the word is dyspnea, but I feel short of breath. But feeding, or poor feeding really, is a sign that things aren't going well. So we've said a couple times that infants are obligate nasal breathers. We said it comes because they need to be able to stay latched onto a nipple for up to 20 minutes or more at a time. And to do that, they have to be able to breathe effectively through their nose. So if an infant is trying to feed, one, that's basically like baby exercise. It's the most activity that they're going to do in a day. And number two, they have to be able to breathe effectively through their nose while they're doing it. And so if they can't do that, that's actually a sign that they may be having some trouble. So most of the time, kids come to the ER because they have bronchiolitis, RSV, and respiratory distress. But I would say, as likely as not, they are also having poor feeding, and you might be dehydrated and need IV fluids. I think that was it for this page. Oh, the last thing I'll just say is about the air entry and wheeze. So this is where, when the doctor's trying to make a diagnosis, they really need to listen to the lung sounds. And bronchiolitis is a very classic sound where you hear what are called crackles or rhonchi kind of scattered throughout, and wheezes scattered throughout the lungs as well. And they're basically just signs that the bronchioles throughout the lungs are occluded with viral particles, inflammatory debris, and that type of thing. And the wheeze is really the sound of air trying to usually escape through really small occluded bronchioles. A lot of people will say that they can hear their child wheezing. I'll be honest, for me, I think most wheeze, you really have to listen with a stethoscope. And oftentimes people hear loud breathing, but it's not true wheeze by medical definition. Okay, I think that was definitely enough. Let's now just go to the practical point of this and look at babies breathing and just talk about what we're seeing. Okay, so let's get right into it and let's look at a child breathing. Here you can see that the child has obvious intercostal and subcostal retraction. So with each breath, you kind of see the ribs flare out a bit, and then you see that shadowing just underneath the lowest rib. You also see some suprasternal or supraclavicular retractions, which are just retractions up here. It's not as obvious because the baby's chin is down, but if you put their head back a little bit, you might be able to see better. And then finally, I see a little bit of nasal flaring and a little bit of head bobbing, but not super severe. So let's look at the next video. All right, so here we can see another example of intercostal retractions where there's shadowing in between the ribs. You also see some shadowing just underneath the ribs, so showing subcostal retractions as well. And then finally, you can just see that the belly sort of pooches out with every breath. And we sometimes call this belly breathing. And it's often just a sign that the diaphragm is really pushing hard whenever a breath is coming in. Once again, we see intercostal retractions here on the patient's left side. On the right is where it's most obvious that there's the subcostal retractions. And then moving up top, you see this very obvious sign of suprasternal retraction. So these are all the signs of respiratory distress. For that patient, you don't see as much nasal flaring, but a little bit is present. And then finally, here, this child's breathing pretty slow, so it takes a second to really see, but eventually you see there, that's that good nasal flaring where, again, what the child's doing is trying to increase the surface area of the nose to get as much air in as possible. All right, and then the final video here is going over grunting, so I hope the audio is coming through. This is really the critical part of it. I'll pause for a second. So you can imagine that if you just heard that audio clip, but you didn't have any video to go with it, then you may just say that just sounds like a baby who's crying. But I'll say you can hear that the sound comes at the end of every breath out, essentially, combined with the fact that you can see the ribs, see that shadowing indicating retractions, and this infant, really is showing true signs of grunting. And again, here from our old picture, this is trying to prevent atelectasis. So every time that a breath goes out, the baby's trying to keep a little bit of pressure in the lungs to prevent this alveolus from collapsing down. Okay, and I think that's about it. So, just a quick run through of respiratory distress and give a little bit of perspective on how doctors are thinking about this. But again, I'll just close with saying, once again, pediatricians are pretty nice people, and it is literally what we are all paid for, is to evaluate infants and children. It is not your job to decide whether your child needs to be treated outpatient, inpatient, in the ICU. That is what pediatricians are here for. So please, if you have any concerns, make sure that you get to a medical provider. But this is really just educational content that hopefully will empower you to make better decisions for your children. And yeah, so thanks so much. I'll make my next video about the diagnosis and treatment of bronchiolitis and RSV, so we can talk a little bit more about what people do at home or what happens when they come into the hospital.